here for the next minutes to discuss this topic that it's very important is individualized treatment in selection in recurrent metastatic squamous cell carcinoma of head and neck. So those are the disclaimers, and those are my disclosures, and some information regarding the agenda and faculty. Today I will be sharing the screen with Dr. Mengshi Shi. And it will be a pleasure to discuss together with you. We will have the first topic will be one size does not fit all, tailoring to every patient in recurrent metastatic setting, unburden the tumor, adapting to tumor burden, and then we will have some clinical case presentations, and then we have question and answers from the audience, and then we close it. Just a couple of things from the housekeeping. You can participate by raising your hand and making your questions, or by using the question and answer function, and you can submit your questions, and then we will answer to them on the question and answer time. There will be some polling questions. They will appear, and your input will be very much appreciated. And the answers are anonymous, so we don't know which one has responded what. And at the end, we will have an evaluation form, so you can scan the QR code and please make your evaluation to help us improving these sessions. Note that the presentations in this webinar will be recorded, but the discussion and the question and answer sessions will not be recorded, okay? So saying this, let's now hear from you, and on a scale of 0 to 10, please rate the following factors based on how much they impact your first-line treatment decisions for patients with recurrent metastatic head and neck squamous cell carcinoma. You have PD-L1 expression, comorbidities, tumor burden, fitness, pace of tumor growth, patient preference, extent of metastasis, caregiver availability. Please vote. We cannot vote for that, so only you. We have already all the results. Okay. So PD-L1 is important. Then we have comorbidities, more important. Tumor burden, something. Fitness, not the biggest one. The pace of tumor growth. The patient preference, not so well. Extent of metastasis, and the caregiver availability, like 8. Okay, so let's now start the presentation. So I will discuss with you that one size will not fit to all patients, so we need to tailor the treatment for every patient. So first of all, you have, starting by anatomical sites. Head and neck cancer is not one entity. We have different entities. By the anatomical part, they arise. So we have pharynx cancer, nasal cavity, oral cavity, larynx. We have a different origins of the tumor. Then we will have extent of metastasis. If the patient has metastasis, the size, the number, the location, because if it's in the lung, could be less important if it has in the neck, because it can impact in the quality of life and it could threat the life. Mutation profile, if it has a high or low mutation load, tumor microenvironment, extent of immunosuppression, extent of T cell infiltration, molecular classification, because this difference can influence patient prognosis. And so that's why it's so important to have this information. So the Pan-Asian guidelines recommend using CPS to guide the first line of recurrent metastatic treatment selection. So as you see in the first line therapy, you have two different branches. You have no platinum-based chemotherapy in the past 6 months or platinum-based chemotherapy in the past 6 months. So starting to the left part, if the patient has not received platinum-based chemotherapy in the past 6 months and the CPS is negative, the standard will be cetuximab plus chemotherapy. Then you have other options, pembrolizumab plus chemo, TPEX, PCA, taxanes, methotrexate, cetuximab, or best supportive care. Always count on that. And then you have CPS more equal to 1. And then you have the standard will be pembrolizumab plus chemo or pembro monotherapy. The choice between the two may be based on CPS, tumor burden, and symptoms. And then you have different other options that you can use if the patient is not indicated to immune checkpoint inhibitors or platinum eligible. For the patient who had experienced platinum-based chemotherapy in the past 6 months, you have the possibility, if the patient is immunotherapy naive, you can do it nivolumab or pembrolizumab. And if the patient has already been submitted to prior immunotherapy, then you have taxane, methotrexate, cetuximab, or best supportive care. Sorry. Regarding the data, as you can see, for patients with CPS negative, no overall survival benefit with pembro with or without chemotherapy. For the ones who have CPS from 1 to 19, there was no benefit on overall survival with pembrolizumab monotherapy and marginal overall survival benefit in favor of pembro plus chemo. For the ones who have CPS more equal to 20, then overall survival benefit, it was in favor of pembrolizumab plus or without chemotherapy. Although we evaluate CPS for each patient to make our decisions, there are some limitations on the CPS testing. First of all, you have intra and intertumor heterogeneity for PD-L1 expression. The studies show that 38% of biopsy samples were found to have a different CPS status when they paired with resection samples. So it's important to have new biopsies when you have a relapse. Testing reliability and reproducibility. It's something that we show that we have difference between different observers, and so we have different testing. The impact of treatment on CPS status. When you compare samples before and after chemoradiation, CPS are different. 32% of local and regional recurrence sites when using a CPS more equal to 20 cutoff. And interpretation and protocol variations. There will be variations between protocols and between pathologist interpretations. So the CPS is important, but sometimes could have some bias, and we use it to choose our treatment most of the time. There was some range of patients and disease and treatment factors that should be considered when you choose the treatment beyond CPS alone. So you have patient-related. On those, you have to consider the performance status of the patient, if the patient has symptoms or not, the patient comorbidities, if he has some organ dysfunction, kidney, liver, lung, bone marrow, the patient preference. Don't forget this. This is very important. Autoimmune disease. And then you have disease-related. Need for fast tumor response. If the patient is very symptomatic, you will need a fast tumor response if he has a very bulky disease. Risk of acute complications, bleeding, airway obstruction, site of relapse, local regional versus metastatic. PD-L1, CPS, tumor burden. And then treatment dependent, residual toxicities from previous treatment, availability of re-radiation or salvage surgery. Mechanism of action of therapy. Other, some social economical environment. If the patient has someone who can care of him, availability of simultaneous palliative care. Always remember that. And so you see in pink the ones that we can be very keen when we look into the patients to see to help our decision on the treatment. So symptoms, need for fast tumor response, risk of acute complications, site of relapse, and tumor burden. And so now talking about unburden the tumor, adapting to tumor burden in recurrent metastatic, and how we should do this. We have low tumor burden. And on the low tumor burden, what are our aims? Prolong survival, to control the disease, maintain or improve quality of life, and prevent new symptoms. This is our aim for those patients. When you have a high tumor burden, what do you need? You need immediate symptom relief. So you need rapid tumor shrinkage. You need to improve quality of life. You need to control the disease. At the end, of course, we all want to have to prolong survival, but there are differences between those two groups. When you see the factors related to tumor burden, you have symptoms, you have the pace of tumor growth, organ dysfunction, if it's imminent or threat of life, for instance, because if it's in the neck, patients could have some trouble in breathing or swallowing. Then you have tumor location. It's different if you have a lung metastasis than if you have a neck disease. Risk of serious complications. That was what I was comment. Depending on the location and the pace of the tumor growth, you can have you can have the patient in risk of breathing, swallowing, or even bleeding because of the carotid artery. You have tumor size, risk of devastating outcomes upon progression, and then you have the extent of the metastasis, including the number and the sites and locations, because it can be candidates for local treatments. Don't forget that it's always an option. High tumor burden typically refers to tumors that are bulky, widespread, rapidly progressing. So those we need a very quick response. And so what do we know about the tumor burden and the quality of life of the patients? So what we know is that the patient can have pain caused by progression of tumor itself. The patient can have bleeding because of uncontrolled tumor growth, or the primary tumor encasement of great vessels, such as carotida or jugular. The patient could experience some speaking difficulties because could be caused directly by the tumor, or the sequela because of the edema regarding radiotherapy that was previously experienced, and they can diminish the mobility of vocal cords, and they can negatively impact patient quality of life. Dysphagia can be caused by the tumor, the primary tumor, by mechanical obstruction, or by a fistula, or in functional dysphagia. And this could lead to aspiration and pneumonia, and is actually the cause of death for some patients, even without recurrence or disease. And this could lead to malnutrition and weight loss. Breathing difficulties, the tumor spreading to the lungs, and airway obstruction. They could be exacerbated by comorbidities, because most of our patients still smoke, and they have these other lung diseases associated. So large tumors, they can exhibit a more immunosuppressive microenvironment, which can affect the response to immune checkpoint inhibitors. So when you have a high tumor burden, you have high anti-tumor cytokines, high hypoxic stress, high immune exhaustion, high immunosuppression, and then you have less immune cell infiltration and less treatment penetration. So tumor burden is inversely correlated with response to immune checkpoint inhibitors therapy in recurrent metastatic setting. So low tumor burden, independently if you are talking about PD-L1 positive, we know a few symptoms and slow growth of the tumor, so they can benefit with immune checkpoint inhibitors alone, or immune checkpoint inhibitors with chemotherapy. But remember, if we are talking about patients with very few symptoms and a PD-L1 very high expression, maybe you can have a monotherapy, so you can have less negative impact on the quality of life of the patients. If you have a high tumor burden, patient is very symptomatic and the tumor has a fast grow, you need chemotherapy. You need chemotherapy for those patients. So to improve the chances of survival, patient need a fast response with a regimen that provides high response rates, low progression disease rates. So chemotherapy may help shrinking the tumor, slow the pace of tumor growth, and prevent the risk of death. Regarding the data, pembrolizumab monotherapy showed a low overall response rate and a low disease control rate, as you can see in all settings independently of the CPS expression. And when you had chemotherapy to pembrolizumab, it increased the overall response rate and disease control rate, making this combination more suitable, especially for the patients who have high CPS expression. When you have cetuximab plus chemotherapy, he has demonstrated a high overall response rate and a low progressive disease rate, so providing another option for the patients with a high tumor burden. As you can see, the overall response rate is 57.6% of the patients. When you look into the regimen with the TPEX, cetuximab, cisplatin, and docetaxel, that does mean that you have only 4 cycles of chemotherapy instead of the 6, and you don't need a portal-vein, and you still have a great response rate, and you still have less patients who have progressive disease even with less chemotherapy. When you look into the depth of response and the early tumor shrinkage, that was something that we talked that it's very important to have the chance of having a better survival for those patients. When you look into these patients, you can see that you have a high depth of response, 51% with TPEX, and you have a early tumor shrinkage of 44%. So you have almost half of your patients had a response, very early response. So in summary, tumor burden should be considered when selecting a first-line recurrent metastatic therapy, and therapy choice should be adapted according to ensure treatment goals are met. Patients with high tumor burden can benefit for chemotherapy-based regimens. With less intensive therapies, such as pembrolizumab monotherapy, are suitable for patients who have low tumor burden with a high PD-L1 status. Tumor burden is inversely correlated with response to immune checkpoint inhibitors therapy. So real world suggests that improved survival for cetuximab plus chemo versus pembrolizumab plus chemo in patients with high tumor burden, regardless of PD-L1 status. So the pembro plus chemo may be suitable for patients with a low tumor burden and positive PD-L1 status. So now I pass to Dr. Mengshi Shi, and he will talk about some clinical case discussion with us.
Thank you, Professor Gomez. Thank you for your kind introduction and excellent talk. I think it is very important for us to consider a lot of factors before initiate the first-line treatment for the recurrent metastatic head and neck cancer patient. So in my opinion, I totally agree with your presentation. And for me, the most important will be the CPS, PD-L1 level, and tumor burden, and the patient's comorbidity. I think this is the most important things we need to think about before the treatments. Now I'm going to share 2 of my patients. We can have some discussion during my presentation. And during my presentation, I would like to invite Professor Gomez to share her professional opinion to let us know how to treat this kind of patient in our daily practice. For all the audience, if you have any question, please leave a message for us and let us know. We will discuss your question in the end of my presentation. Okay, next slide, please. I have nothing to discuss. Next. Okay, the patient case number 1. This is a 52-year-old male. This patient does not have any underlying disease before except cancer history. He is a worker. He has a smoking, alcohol consumption, and the bindle not showing. The smoking history is 25 pack a year. Alcohol history is half a bottle of whiskey per day for 50 years. His ECOG performance is really good. Performance status was 1. This patient was firstly diagnosed to have tongue cancer in 2019. He received a surgery, and the pathology stage was PT2N0M0. In 2021, he was found to have the tonsil cancer. He also received the tonsillectomy at that time. The pathology stage was PT2N0M0. In 2022, this patient was diagnosed to have left side buccal cancer. He received a tumor-wide excision with flap reconstruction. The pathology stage was T4N0M0. Because of the advanced stage, he received the adjuvant chemoradiotherapy after the surgery in August 2022. Then after the treatments, he was lost to follow up. He returned back to our outpatient clinic 1 year later in October 2023 with a presentation of headache, facial swelling, sore throat, dysphagia, dyspnea. The MRI study at that time showed the tumor had local recurrence over the tongue base and the soft palate with nasal cavity and the scalp base invasion. We do the biopsy and the pathology confirmed this is a squamous cell carcinoma. We also do the PD-L1 testing. The CPS was 18, the TPS was 70%. Okay, next slide. This is the MRI study at that time in October 2023. For the left side MRI image, you can see there's a huge tumor with local recurrence over the soft palate with upward invasion to the scalp base and the nasal cavity. For the right side MRI image, you can clearly see there's a huge tumor recurrence from the mouth floor and occupied the entire oral cavity. So I think this patient had a very huge tumor recurrence at this time. So it can be seen as a patient with a very high tumor burden. Okay, next slide. So it's time to hear from the Professor Gomez's professional opinion based on this patient's presentation. Which clinical factors would you prioritize when making your first-line treatment decision?
So we have a patient who has already been submitted to chemoradiation, surgeries, a lot of surgeries, and now has a local recurrence that is very extensive disease, and the patient is very symptomatic. Although we look into the CPS score, that is a very high CPS score, but the patient needs a response. He needs to improve the symptoms. He needs to have control of disease very quickly. And so for sure he needs chemotherapy. And so for this patient, I will go for chemotherapy. And if possible, in my clinical practice, in this patient, I will experience the TPEX because if he has a very good response, you can see after the first cycle, and then you still have immunotherapy for a second line that for sure you will need for the second line. So, but it will depend on what you can use that is approved in the institutions. But for me, this could be a very good candidate for TPEX, but it could fit for chemotherapy plus pembrolizumab too. He needs chemotherapy, that's for sure.
Okay, so you prefer the TPAS regimen in this kind of patient. And I just wonder, do you use the extreme regimen in your country, in Europe? Or you never use the extreme, now you move to the TPAS regimen?
Nowadays we don't use extreme anymore. We substitute by TPEX because it's easier for the patients. Only 4 cycles. We don't need the portal vein, and so it's quickly to start the treatment, and you can see the results within the first cycle. You can see the results if the patient will respond. There are patients who not respond. So yeah, but it's always something that you can see and that you can act very quickly.
Okay, so in this case, this patient have both a very high CPS level and please back to the last slide, sorry.
There is this one.
Okay, last one.
And the last one?
Yep. Yeah, I still have some question to
okay.
Okay, so in this kind of patient, this patient has both a very high CPS and a high tumor burden. Which factor do you weight more heavily in your treatment decision making? You will pay much more attention on the CPS level, or you just pay attention on the tumor burden status? What's your opinion?
For me, the most important will be the tumor burden because it's the one that makes the life of the patient in threat. So, first of all, tumor burden. And then, with the tumor burden, if it's high or low, then we look into the CPS.
Okay, so I'm totally agree with you. In my opinion, I also pay much more attention for the tumor burden status because if this patient had a very high tumor burden, that means this patient need a rapid response and also it need a chemotherapy combination. If you use the immune checkpoint inhibitor alone, monotherapy, I think it is not so effective in this kind of patient. So if you need to treat a patient with a very high tumor burden, I always use the TPAS regimen in this kind of patient because all we know the TPAS regimen will have the very high rapid to response and also had a lower PD rate in this kind of patient. And also, okay, so is there any combination besides TPAS regimen in your daily practice? I mean the statistics-based regimen other than TPAS regimen. I just want.
We use it most of the time. It's TPEX. We can change from cisplatin to carboplatin if the patient has not fit enough for that, but still with the platinum and taxanes and cetuximab.
Okay, yeah, some patient was quite elderly and fragile. It is very sometimes they are intolerant from the TPAS regimen. So so if we can change the cisplatin to carboplatin, I think the toxicity will become less and less, and more patient can be tolerant. Okay, next slide, please. Okay, so let's back to my patients. This patient present to our outpatient clinic in November 2023 because this patient is quite symptomatic. He has dysphagia and dyspnea. So we do the tracheostomy and the nasogastric tube feeding at the beginning. And after his condition becomes stable, we start a palliative chemotherapy. This patient has a very high CPS level and also has a very high tumor burden. So as we mentioned earlier, this kind of patient who have a very high tumor burden, they need a rapid response. According to our previous experience, if the patient cannot control their disease in the first line treatments, it is seldomly for them to move to the second line treatments. Always they just receive the hospice care in the next line treatments. So the prognosis will become very poor in that situation. So the first line treatments for this kind of patient is very important. And according to our previous experience, the TPAS regimen usually has the rapid response. The time to response was short, and the PD rate was lower, and the response rate is also higher. So in this situation, in this patient, we suggest our patient to have the TPAS regimen. And after the TPAS regimen, the MRI study showed a partial response. And after the 8th cycle of TPAS regimen, we moved to the cetuximab maintenance in May 2024. And this patient had a regular follow-up under cetuximab maintenance. And in December 2024, we found the tumor has slightly progression. And the PFS of cetuximab in our patient was 13 months. And in that time, because the tumor has slightly progression on cetuximab maintenance, we have two options at this point. One is to rechallenge the previous regimen, that is TPAX. Another one is to move to the second line treatments. In this patient, for me, because the taxane was not failed at that time, and also the taxane-free interval was more than 6 months. So I decided to challenge the TPAS regimen in December 2024. The initial response was just stable disease, but the tumor got progressed after 3 cycles of TPAS regimen rechallenge. Okay, next slide. This is our recent retrospective study to investigate the prognostic impact of tumor burden on the efficacy of the first-line treatments for recurrent metastatic head and neck cancer patients. We use the propensity score matching and include 252 recurrent metastatic head and neck cancer patients. Our patient was divided into high tumor burden group and low tumor burden group. For each group, there are 126 patients. And for each group, patient was further divided into PPF group and the EPF group. PPF referred to patient received the pembrolizumab plus chemotherapy as the first-line treatments. EPF referred to the patient received cetuximab plus chemotherapy as the first-line treatments. Our study aimed to compare the efficacy of PPF and the EPF in a patient with a high tumor burden and a low tumor burden. The PD-L1 test is quite similar between each groups. The p-value was insignificant in patients with a high tumor burden and a low tumor burden group. Next slide. For the results, in our retrospective study, high tumor burden patient receiving cetuximab-based regimen showed a longer PFS than those receiving pembrolizumab-based regimens, regardless of PD-L1 expression. You can see the median PFS results. For patients with high tumor burden and the PD-L1 positive, the median PFS of EPF was 5.8 months, and the median PFS for PPF was just 4.8. The p-value was significant. For patients with high tumor burden and the PD-L1 negative, the median PFS was 6.3 for EPF and the 2.5 months for the PPF. The p-value was also very significant. Next slide. The result, in terms of the overall survival, the result was quite similar. In our retrospective study, high tumor burden patient receiving cetuximab-based regimen also showed a longer overall survival than those receiving pembrolizumab-based regimen, regardless of the PD-L1 expression. Here is the result of the overall survival. You can see the median overall survival for the PD-L1 positive patient. The median overall survival was 9.9 months for EPF group and 6.4 months for the PPF group. The p-value was quite significant. And for patients with PD-L1 negative, the median OS was 9.1 months for the EPF group and 6.0 months for the PPF group. The p-value was very significant. So based on our retrospective study, we can easily tell for patients with a very high tumor burden, because it is reasonable for them to receive the cetuximab-based chemotherapy as the first-line setting, because it can provide this patient with a better survival, regardless of the PD-L1 expression. Next slide. So back to our patient. This patient received the TPAS regimen at the beginning as the first-line setting. This tumor, you can see the MRI study. The tumor was responsive very well to the first-line TPAS regimen in May 2024. And after 8 cycles of TPAS regimen, the patient started to have cetuximab maintenance until December 2024. We can see the tumor had a slightly progression to the cetuximab maintenance in December 2024. Although we start to recharge the TPAS regimen, but it does not work very well. So I have a question for Professor Gomez. If you find the tumor has slightly progression on the cetuximab maintenance, will you choose to recharge the original regimen, or you will move to a second-line treatment? What's about your opinion?
It's a very difficult decision at that time, but probably I will try to make immunotherapy here because what we know is from the biological part is that the cetuximab will enhance the ADCs, and it may help to have a better response from immunotherapy after. And we still have, if the patient progress after immunotherapy, such as nivolumab, is the only that we can do in our country. In second line, we cannot do pembro, but after nivolumab, if the patient progress, you still have the option of the taxanes with cetuximab. That is based on the Erbitax study that has a very good results without the cisplatin, because the patient has already experienced platinum and could lead to the maximum doses of cisplatin. And so maybe, but it's easier if now we see the results to try a different thing that you experience. But yeah, maybe we can try the immune checkpoint inhibitors because of the mechanism of action. So the enhancement of the cells could lead to a better response with immunotherapy, but it's only theoretical.
Yeah, thank you very much. Okay, next slide, please. And back to our patients, we returned to the TPAS regimen at the beginning, but it does not work very well. Tumor has progressed after 3 cycles of TPAS recharge. So we moved to the second line treatment for the recurrent mets setting. As we know, after failed of the cetuximab-based chemotherapy, the immuno checkpoint inhibitor was the standard second line treatment for this kind of patient. So we suggest our patient to receive the pembrolizumab in February 2025. I will also add on the EGFR TKI, afatinib in this kind of patient, because there is a phase 2 study initiated by Professor Hong and Professor Gao in Taiwan. Their study demonstrated that afatinib can increase the efficacy of pembrolizumab in a patient of platinum refractory recurrent mets head and neck cancer patient. So sometimes we will use the pembrolizumab plus afatinib in Taiwan. So we use this combination in this patient. And in August 2025, the MRI study showed that the tumor had a partial response. So the PFS2 and the overall survival for the first line and second line treatments in our patient was at least 22 months. I think this treatment strategy is quite nice and can control the disease in a very well and prolong the patient's survive. Okay, next slide, please. Here is the MRI study in August 2025. You can see the tumor response again to the second line pembrolizumab plus EGFR TKI. The tumor got a very well shrinkage. This patient still continue the pembro plus afatinib until now, and everything is fine, and tumor is under very well control. Next, please. Okay, let's see. Here is the case number 2. This is a 68-year-old male. He has an underlying disease of type 2 DM. He under regular medication control. He is also a worker. He has smoking, alcohol consumption, and banana chewing. The smoking history was 20 pack year, and the alcohol history was 2-liter beer every day for 10 years. And his performance is quite well. The ECOG performance was 0. This patient was diagnosed firstly to have tongue cancer in 2018. This patient had a surgery at that time. The pathology stage was PT3N2M0, stage 4B. And after the surgery, because of the advanced stage, he received the adjuvant chemoradiotherapy with the cisplatin every 3 weeks. And after that, he received a regular MRI and CT scan to follow up his disease. In September 2021, he was incidentally found to have bilateral lung metastasis. But however, this patient did not have any symptoms. No cough, no dyspnea, no chest tightness. When do the PD-L1 testing from the archive tissue, the CPS was 50 and the TPS was 50%. Next slide. Here's the CT scan of this patient. You can see bilateral lung has small tumors. It is unresectable. So this patient, the tumor was small and there's no symptoms. So I think this patient is a case with a low tumor burden. Next slide. So it's time again to hear from Professor Gomez. Based on this patient's presentation, which clinical factors would you prioritize when making your first-line treatment decision?
So as you said, first is a low burden disease. So it's our first segmentation. The patient is asymptomatic. That is very good. We don't need a fast response. We have time to wait. The lesions are in the lungs. It doesn't seem that will compromise the breathing or something. It seems that it's control. So it has a CPS that it's very high. It's 50. So in this case, probably I will go for monotherapy with pembrolizumab, but I will discuss with my radiation oncologist the possibility of having some of the lesions, if we have a response, to have stereotaxic radiotherapy for some lung lesions, depending on the response too.
Okay, so you always use the pembrolizumab plus radiotherapy to control the tumor?
It will depend on the number of lesions. We have to discuss with the radiation oncologist. Sometimes they start with the radiotherapy and then we do the immunotherapy just after, or we do immunotherapy and depending on the response, they will do it. If there is residual disease, they can do it. But it will depend on the discussion with radiation oncologist on MDT.
Okay, so for lung metastatic tumor, if you do the radiotherapy and pembrolizumab, how about the toxicity in this kind of treatments?
No, usually
And
we don't combine it together. So or either they started with radiation therapy and then when they finish we start immunotherapy. We usually don't combine it. Even if they are on pembrolizumab and they have a good response and we think that it will benefit from having radiotherapy, we stop pembrolizumab during the radiotherapy and then restart it again after the radiation therapy. Usually don't combine it together. It could be combined, but it's not adding something, and I think it will not add nothing to the patient unless toxicity to have immunotherapy with radiation. So doesn't benefit the patient.
okay, so you prefer the sequential use, the
Yeah.
radiation first and followed by the pembrolizumab. Okay, and how about the pneumonitis? Does the incidence will be increased? The severity will be increased after the radiation?
We didn't experience that with those kind of patients, and that's why they need to be very selected. Because if it's a patient that has a very low lung function because of the tobacco use and so on, sometimes with a great emphysema, sometimes it's not the best candidate for experience this sequential regimen. But if the patient is very fit, and it seems that this patient was very fit, it was an ECOG 0, no symptoms, no cough, no nothing, and this patient usually they go well with the sequential treatment, but we never know. It could happen. It's not something that we see so often as when we treat lung cancer patients, we have more pneumonitis than the head and neck patients, probably because to the lung condition at the beginning. So that's why I think it's different. But every patient that experiences immunotherapy is different, and we have now the experience with the breast cancer. It's even worse. They have all the side effects. So I think it's not the same for all pathologies. And I think head and neck patients, they go pretty well with the immunotherapy most of the time, and we can do it safely.
Yeah, okay, we should pay attention on the IRA, but we do. And I find pneumonitis is seldomly happen in our head and neck cancer patients, like Professor Gomez experience. And I just wonder, for the patient with low tumor burden, you suggest the pembrolizumab monotherapy. Is your treatment decision will be different if the CPS is between 1 to 19 and more than 20?
Yes. Usually, the ones that we do monotherapy is the ones who have CPS more or equal to 20, because it's the one on the studies that has more benefit from the treatment. So for the ones between 1 to 19, the benefit it's not so expressive, but it will depend, because if the patient is asymptomatic and imagine if he has CPS of 18, and it has no symptoms and it's like this, perhaps I will go for monotherapy anyway, in spite of not being 20. But imagine if it's a patient with CPS of 2, the probability that the patient has of having no response with immunotherapy is very high in monotherapy. And so you will give treatment for a patient who has no benefit and only toxicity. So it has no meaning. So it's not only the CPS more equal to 20. So CPS more equal to 20 with low burden disease for sure, asymptomatic. Monotherapy, the ones between 1 to 19, it will depend on the patient, on the disease,
Recording stopped.
the expression too, because like in between 1 to 19 it will be tricky, but if it's more close to the 20, I will be more in favor of monotherapy.
Okay, thank you for your professional opinion. Okay, next slide, please. Okay, so let's move back to our patient. This patient have a symptomatic lung metastasis in September 20 and 21. So because this is a case with low tumor burden and asymptomatic, so we suggest our patient to receive the pembrolizumab monotherapy. And after the pembrolizumab treatments, the response is quite well. The tumor shrinkage very well, and MRI showed that the tumor is nearly complete response. The PFS in this patient was 32 months. However, in June 2024, the lung mets start to have slightly tumor progression. Next slide. Here is the CT image of our study. You can see the CT, the left side CT, the tumor responds to the first line pembrolizumab very well. The tumor shrinkage very well, and the tumor continue response to the pembrolizumab until the June 2024. In June 2024, you can see the right side CT. The tumor has disease progress and become larger and larger. So in this time, maybe we need to move to the second line treatments. Next slide, please. So in this situation, this patient was failed of pembrolizumab, so we need to move to the second line treatments for this patient. As we know, although there are no prospective study to investigate the second line treatments after the failure of the pembrolizumab, but according to our experience, in this situation, cetuximab-based regimen can provide a survival benefits in this kind of patient. So we suggest our patient to receive a TPAS regimen in June 2024. And after the treatments, the CT scan showed the tumor had a partial response. The tumor responds very well to the TPAS regimen. And in January 2025, this patient shift to cetuximab maintenance because the tumor shrinkage very well. And this patient received the cetuximab maintenance until now. The PFS of cetuximab in our patient is at least 50 months. Next slide. Here is the CT scan of our patient. In September 2024, the patient received TPEX as a second-line treatment. The tumor start to shrinkage, become smaller and smaller, and continue to respond until December 2024. So we let our patient to have the cetuximab maintenance. And this patient still have cetuximab maintenance until now, and his disease is under very well control. The tumor is controlled very well, but you still can see there's some tumor over the bilateral lung field. Next slide. Okay, so this is my CAS2 presentation, and I think these two cases are very typical cases in our daily practice. It is quite similar as your patient. And that's all my presentation today. And I would like to thank all the audience for your attention. And I would like also to thank Professor Gomez to give us a lot of professional opinions and help us how to treat this kind of patient in our daily practice. Thank you, Professor Gomez. Thank you.
Exactly. I think we can have some questions from the audience. So if you want to make yourself the questions, please raise your hand and we will give you the word, or you can participate by the Q&A. Okay, and I can have some questions here. For platinum-resistant disease with early relapse post-chemoradiation, what is our regimen of choice? So, Professor, you want to have your opinion for platinum-resistant disease with early relapse? I think it will be less than 6 months after chemoradiation. What could be your choice? For us, it's the ones that fit for nivolumab, right?
Yeah, for the patient with platinum refractory and early relapse head and neck cancer, the prognosis is generally very poor, and the treatment response is not so good. So it is also a big challenge in our daily practice. And in this kind of patient, I usually focus on their tumor burden and the CPS status. If this patient is a case with a very high tumor burden, I will use the cetuximab plus taxane with or without platinum. I think both is okay, but my point is cetuximab plus taxane. I think this will be effective for this kind of patient, regardless of the PD-L1 expression. However, if the patient just have a very low tumor burden and high CPS level, I think for this kind of patient, the pembrolizumab monotherapy with or without chemotherapy is a very good first-line treatment in this kind of patient. So my point is the same like other patients. If this is a very high tumor burden patient, I think the chemo combination, especially the taxane, will be very effective in combination with the cetuximab in this kind of patient. However, if this is a low tumor burden cases, I think the ICI monotherapy is enough. What's about your opinion, Professor Gomez?
Yeah, we can use it here too because it's a platinum resistant. We can do nivolumab without the CPS expression because it's approved independently of that. It's the very small patients that we can do like this. It could be an option, but I agree with you that cetuximab plus taxane could be a very good option for having some response if the patient is in need of a response. And something that they ask us, and I think it's good, is if on this relapse, if we would go for another biopsy. Yeah, I would say yes, because as I show you in the presentation, it shows that we have difference between the samples on the previous tumor that was submitted to surgery and the ones who had already submitted to chemoradiation. So I would say that makes sense to make another biopsy if it's accessible and it's not so bad for the patients. Let me just check. In the real world, will Dr. H calculate TBS for all patients before choosing first-line treatment?
Yeah, we will test the CPS and TPS before our first-line treatments. If the patient had a high CPS, maybe we can start with the ICI and the first-line treatments. If the CPS is low, we start with the cetuximab based regimen as the first line treatment. And for the second line, if the TPS is positive, more than 50%, maybe we can use the pembro as a second line, or maybe the IC is positive, we can use the nivo as a second line. I think both CPS and TPS are valuable and needed before our treatment. So we need to collect all the data and all the testing, and then we can make a perfect treatment plan for our patient, and the sequence will be the best, and the survival and response will also be the best.
I think one of the questions here, maybe it could be this idea when they ask you this question about looking for the TPS for every patient, is that if we look into low burden disease or high tumor burden, if you have a high tumor burden and you need a response, sometimes since the data that you collected, sometimes the combination with chemo and cetuximab is better than the other one, if makes sense to make for all the patients or only the low tumor burden disease patients. I think it was this idea when they talk about making for all or or dividing in low burden disease or I think it's the meaning.
I'm misunderstanding the question.
No. You understand well. It was if you do to everyone, and I was in favor to. I will say the same, but probably when we decided our first line treatment, we consider more or less the CPS or TPS dependently of the other things. Like if you have a high tumor burden, you will not wait sometimes for the result of this because probably we will go immediately for cetuximab chemotherapy regimen and independently of the CPS. But it's good to have the CPS because as you comment on the second line, it will be helpful to know if the patient has a high CPS or not, and it will help a lot with this. So I think it's very important that we can have these options. And I think we need to close the question and answers so we can stay here for the rest of the night. But I think you have another plans. And so now again to you, and let's hear what was your opinion now from a scale 0 to 10. What represents the thing that you will impact your choice on the first line treatment decision? You can vote, please. Let's see if we have some impact after our presentations. If someone changed their minds regarding the presentations or not. So do you have the results of your vote? Let's see. So PDL1 expression still high, and comorbidities 8, 9. Tumor burden 10. So you were very convincing, Dr. Mengshi. Tumor burden now 10. Good. Fitness still important, of course. Pace of tumor grow very high, so high in 9, 8 and 9. So patient preference more or less the same. Extent of metastasis doesn't change so much, and the caregiver availability. So I think it was it was really good that people recognize that it's important, the pace of tumor grow and the tumor burden. It was the aim of our presentation too, to see this. And so just to thank you, Dr. Menchi, to co-share this session with me. And thank you all to attend. And please don't forget to scan this QR code and make the evaluation form, please. It will help us a lot. Thank you so much for being here. Thank you, Dr. Menchi.
Thank you, Professor Gomez. Thank you, everyone. Thank you. See you.